I'm Dr. Maury Markman from City of Hope, and in this final segment of Minutes with Markman, dealing with an update on the status of HPV vaccination as a cancer prevention strategy, I tackle the question of what next? Are we now finished answering relevant public health questions related to this critically important vaccine strategy? The answer to this question is absolutely no. We have come so far, but we have so much farther to go to optimize the use of this approach, HPV vaccination, as a strategy to prevent cancer. First, I note a number of questions where we have some provocative existing data, but we need to tease out more to demonstrate the true benefits. Here's a question for women who have not been previously vaccinated, but undergo a surgery for, unfortunately, the development of a HPV-related precursor, cancer precursor. So they're now free of disease. They don't have cancer, but they had an HPV-related precancerous abnormality. Is there a benefit at this point to vaccinate? Provocative data suggests the answer to this may very well be yes. Even if the abnormality found was related to a component in the vaccination, it is possible that now vaccinating them will decrease the risk of developing a subsequent abnormality. And certainly that may be the case, and you can understand very clearly why that might be the case, if the abnormality, if the vaccine is going to cover things that were not associated with the HPV abnormality in that cervical lesion surgically removed. So that's one issue that needs to be dealt with. But perhaps the most important question is, and in particular in the light of the United States regulatory decision about a single dose, is to say, wait a minute, we do not have the answer to this question yet. Yes, the data were provocative. Yes, they're very exciting. Yes, a single dose may be wonderful today in parts of the world where we actually would be very difficult to give more than a single dose. But do we know the long-term effects of a single vaccine dose compared to 2 doses? What about 3 years, 5 years, 10 years later? Are we going to be in a situation where after only a single dose, the benefits will wane, such that the cancer prevention strategy may be less effective? We simply don't know. The second issue, and the really important issue here, is these studies have been very appropriately conducted, mostly in women and mostly in cervix cancer. What about oropharyngeal cancers? What about protection in males as related to oropharyngeal cancers? Is a single dose as effective as 2 doses as a cancer prevention strategy in oropharyngeal cancer? And again, specifically in males, but we have less information than we do with females. We do not know, which is why there needs to be more investigation, which is why the statement that a single dose is just as good, provocative thought, but the data simply are not there to make that recommendation, certainly not in the United States today, in my opinion. And finally, I think it is important to say that, yes, we need more investigation. Yes, we need more trials. But it is relevant to note, and particularly when we're talking about non-inferiority studies, that the sample sizes are massive to prove non-inferiority, different than trying to prove superiority. So the question is, how do we develop these reasonable trials, recognizing someone has got to bear the cost, the time, the effort, making sure that it is a public health strategy. Studies need to be robust. They need to be meaningful, but they also need to be feasible. These are questions that I hope that pharmaceutical companies involved, government regulators, and very importantly, the academic oncology, cancer prevention community researchers can join together to continue this journey to optimize the use of this spectacularly successful cancer prevention strategy. And I thank you for your attention.